Hello everyone, this is Dr. Vanna Patel and today I am taking the topic on cervical cancer. What is cervical cancer? Actually, cervical cancer is the gynecological cancer that originates from the uterus. Means the gynecological cancers can originate from the uterus, ovaries, cervix, vulva, vagina, fallopian tubes and peritoneum. So these includes the cervical cancer, ovarian cancer, uterine cancer, vulval cancer, and the vaginal cancer. So epidemiology is cervical cancer is the third leading malignancy among the women after the breast and the colorectal cancer worldwide, with 569,000 new cases each year. It occurs at disproportionately higher rate in less developed countries, likely because of reduced access to the screening as well as the high cost of vaccination for HPV. It is one of the leading causes of cancer death among middle-aged women, primarily from the lower socio-economic classes with poor access to the medical care and routine screening facilities. Over the past 30 years, the increasing proportion of young women affected by cervical cancer has ranged from 10 to 40%. Now, the etiology and the risk factors. Sexual activity is the major cause of the cervical cancer, and it is usually believed to be the sexually transmitted disease. Means nowadays the cervical cancer is viewed as the STD. So early age of onset of sexual activity, especially before the 16 years of age, or the onset of sexual activity within 1 year of menarche, or if the woman is having multiple sexual partners, or there is a history of genital warts or multiparity. So all these factors are responsible for causing or are the risk factors for the development of cervical cancer. Now, why it is so why the sexual activity is considered to be the important factor for causation of the cervical cancer is because during the early reproductive life, the cervical transformation zone is more susceptible to the oncogenic agent human papilloma virus. So, what is transformation zone? Transformation zone is that area in the cervix near the opening of the external cervical canal. So, where the columnar cells have major tendency to get converted into the squamous cell. That is, the columnar cells gets converted to the squamous cells, and this can lead to this abnormal multiplication or conversion of the cells can lead to the dysplasia or the cancer formation. So HPV 16 and HPV 18 are the types most commonly associated with the cervical cancer. Next is the cigarette smoking. Cigarette smoking has been identified to be the significant risk factor for cervical cancer because cigarette smoking not only reduces the immunity or the immune capacity of the patient, making him more susceptible to develop the cervical cancer or the infection with the HPV virus. And also the byproduct of the cigarette is responsible, or it is having a carcinogenic active factors which is responsible for formation of the cervical cancer. Third is the oral contraceptives. A higher incidence of cervical cancer, especially the adenocarcinoma of the cervix, is observed in patients with prior oral contraceptives. Alteration in the human immune system. Alteration of the immune system are associated with the increased incidence of cervical cancer, as exemplified by the fact that patients infected with the HIV and those taking the immunosuppressive medications are at higher risk of developing both the pre-invasive and the invasive cervical cancer. Sexually transmitted disease with the chlamydia and the genital herpes is also associated with increased risk of the HPV infection. So the signs and symptoms are postcoital and intermenstrual bleeding. The second is postmenopausal bleeding. Less commonly, advanced cervical cancer presents with the foul-smelling vaginal discharge, pelvic pain, and sciatica. or the renal failure due to the urinary tract obstruction. All these, like the renal failure due to the obstruction of the urinary tract, is usually seen in stage 3 and stage 4. So now the screening and diagnosis. Pap smear is the most commonly used screening test, or it is the most cost effective test, which is very easy to use and the reliable screening test for the cervical cancer diagnosis. Now, the current screening recommendations are: the American College of Obstetricians and Gynecologists recommends that sexually active women aged 18 years or older be screened annually until 3 consecutive normal pap smears, after which screening may be done less frequently, every 2 to 3 years. The American College of Surgeons recommends that screening begin at least 3 years after the onset of vaginal intercourse, but no later than age 21, and it should be performed every year with conventional cervical cytology smears. After the age 30, HPV DNA testing should be added to the cervical cytology for screening. Diagnosis: a biopsy sample must be taken from the suspicious lesion, because many a times pap smears are having it gives a false positive result. So it is always a better option to go with the biopsy. And if the biopsy samples have taken and it shows the cells which is suggesting of microinvasion, and if the patient does not have a grossly apparent invasive cancer, a cone biopsy should be done. For accurate staging of clinically occult lesions, sufficient underlying stroma must be obtained to allow for adequate assessment of the depth and width of invasion below the basement membrane. Squamous cell carcinoma. The pathology of cervical cancers are squamous cell carcinoma, which accounts for 80% of all the cervical cancer. That is, it is the most common cervical cancer. And routine screening by pap smear has resulted in a decline in the incidence of this subtype. Next is the adenocarcinoma, which accounts for 20% of all cervical cancer. Third is the aggressive subtype. This is the very aggressive type of cervical cancer, and it is having a poor prognosis. Rare tumor types, which includes lymphoma, sarcoma, melanoma of the cervix, and these are also very rare. It accounts only for 1% of all the cervical cancers. Now the staging. Cervical cancer is staged clinically after a histologic diagnosis of cervical carcinoma. An examination is done to determine whether the tumor is confined to the cervix or it has involved the adjacent structures like the bladder or the rectum or the pelvic bone. So a thorough examination needs to be done to see at which stage the patient has reported with the cancer of cervix, and it also helps to decide the prognosis of the cancer. So FIGO classification for the cervical cancers are the most acceptable staging method, which is used to clinically stage the tumor. FIGO stands for International Federation of Gynecology and Obstetrics. So now we'll be seeing in detail about the staging of the CA cervix. Stage 0 means carcinoma in situ. Intraepithelial carcinoma, that is, it is not spread to the adjacent structure. There is no involvement of the lymph nodes. The metastasis has also not occurred. Stage 1 means invasive carcinoma, which is again confined to the cervix only. Now, stage 1 is again subdivided into stage 1A, 1 and stage 1B. So this in stage 1A, the invasive cancer is identified only at the level of stroma, and it has not spread to the adjacent lymph nodes or to the distant sites. In stage 1A1, the measured invasion of stroma is 3 millimeter to 7 millimeter, 3 millimeter, or it is less than the 3 millimeter. The depth is 3 millimeter or less than 3 millimeter, and it is 7 millimeter wider. And again, it has not spread to the lymph nodes and no distant metastasis is there. In stage 1A2, The depth of the stroma is now more than 3 millimeter, but it is less than 5 millimeter. So the depth of the stroma is between 3 to 5 millimeter, and the breadth or the breadth of the tumor is not more than 7 millimeter. Next is the stage 1B, means the lesion is now greater as compared to the stage 1A. However, it is confined to the cervix only. So in stage 1B1, now the size of the tumor has increased. Earlier it was in millimeters, now it has increased to centimeters. So the size of the lesion is about 4 centimeter or less than 4 centimeter. And in stage 1B2, the size is more than 4 centimeter. Now comes the stage 2. Again, the stage 2 is divided into two, stage 2A and stage 2B. In stage 2, now the cervix has descended down towards the vagina. However, it has only involved the upper two-third of the vagina and not the lower one-third of the vagina. So in stage 2A, there is involvement of upper two-third of the vagina and no perimetrial involvement is seen. But in stage 2B, the upper two-third of the vagina is involved along with the involvement of the perimetrial. In stage 3, the cancer has now spread beyond vagina, means in the lower part of the vagina. Earlier it was confined to the upper two-third, now it has involved the lower one-third of the vagina also. And along with that, the adjacent wall of the pelvic bone is also involved. The size of the tumor has increased, so there will be compression of the ureters, and this will cause the backflow of the urine, leading to hydronephrosis, and then in long standing case it can lead to non-functioning kidney failure. So in stage 3A, there is no extension onto the pelvic side wall, but the lower third of the vagina is involved. But in stage 3B, extension has occurred to the pelvic side wall along with the hydronephrosis or non-functioning kidney. In stage 4, now in this stage, all the organs which are adjacent to the cervix has been involved, like the bladder in front or the rectum behind. So along with this, there will be involvement of lymph nodes and distant metastasis will be seen. So in this stage 4, we can see that the now the tumor has crossed beyond the cervix or the uterus and has involved all the adjacent structures. So in this diagram, it can be seen like in stage 1, the maximum depth is not more than 5 millimeter, and the tumor is confined to the cervix only. In stage 1B, again, the depth is continuously increasing. Like in stage 1B, the depth is less than 2 centimeter. In stage 1B2, it is between 2 centimeter to 4 centimeter. And again, in stage 1B3, it is increased more than 4 centimeter. Now in stage 2, the perimetrium has been involved. So in stage 2A, perimetrium is not involved, but the upper two-third of the vagina is involved. But in stage 2B, along with the upper two-third of the vagina, the perimetrial involvement is also seen. In stage 3, there will be, see, the size of the tumor has increased and it has crossed the lower one-third of the vagina also. So now it has involved the lower one-third of the vagina. The depth has increased, and with time in stage 3B, we can see that it has now crossed and has involved the wall of the pelvis along with the compression of the ureter, leading to hydronephrosis and kidney damage. In stage 3C, there is involvement of the lymph nodes, particularly the para-aortic lymph nodes. In stage 4, the entire organs which are adjacent to the cervix is involved, like the bladder or the rectum. Along with this, there is distant metastasis. So this is the PIGO classification of staging of CA cervix. So now we'll be seeing the treatment of the same. In stage 1A1, since the depth of the tumor is less, it is less than 3 millimeter, or so it can be easily treated with the conization of the conization procedure of the cervix. In this procedure, a cone of the cervix, a conical area of the cervix is being removed, and particularly the transformation area. As discussed earlier, what is transformation area? It is the area where the colonal cells are converted into the squamous cells, and if it is uncontrolled conversion of the cells occurs, then it can lead to the tumor formation. So in conization procedure of the cervix, the aim is to remove the transformation area of the cervix. If the but this is done only if the patient wants to conceive. But if the patient does not want to conceive, then simple hysterectomy is done. It could be abdominal hysterectomy or vaginal hysterectomy. In stage 1A2, where the depth has now increased and it is between 3 to 5 millimeter, so radical hysterectomy is the choice of treatment with pelvic lymphadenectomy. Along with this, radiotherapy is done. In stage 1B1, the tumor is in centimeters. It is 4 centimeter or less than 4 centimeters. So again, radical hysterectomy with pelvic lymphadenectomy along with chemoradiotherapy. In stage 1B2, the tumor has increased more than 4 centimeter. So again, radical hysterectomy along with chemoradiotherapy. Now in stage 2A and 2B, we have seen that the upper two-thirds of vagina is involved along with the parametrium. So in this, radical hysterectomy along with chemoradiation is the choice of treatment. In stage 3A, where there is involvement of the lower one-third of the vagina, chemoradiotherapy is the choice of treatment. And in stage 4A, where there is local extension of the tumor to the pelvic wall, chemoradiotherapy with primary pelvic extension. So what is extension? In this, the entire pelvic organs are removed. All the pelvic organs like the bladder or the rectum, along with the uterus, ovaries, the ligaments, the supporting ligaments of the uterus, all these are removed. So primary pelvic exenteration is the choice of surgery, which is done in last stage, that is stage 4A. And stage 4B, where there occurs distant metastasis because of the involvement of the lymph nodes. The patient has landed up into the palliative care, and so the palliative chemotherapy or radiotherapy is done. So now we'll be talking about the prevention of the CA cervix. Vaccination of the young girls should be done for preventing the HPV infection before they are sexually active. And education. The Center for Disease Control and Prevention emphasizes the role of preventive education in supporting awareness of the HPV, its risk factors, and with the ways to reduce the risk. Now, we'll be seeing the sequelae which are specific to the surgery or the chemoradiation. So, because there is disruption of the sympathetic and parasympathetic nerves during the surgery, it could lead to the bladder or the rectal problems like the urinary urgency or the incontinence, constipation, incomplete stool evacuation, or the fecal incontinence. Because of pelvic lymphadenectomy, lymphedema could occur, and because of separation of the uterosacral ligaments, which is done in the pelvic exenteration surgery, or because post-radiation fibrosis, There may occur disruption of the ovarian blood flow, causing premature ovarian failure, and resection of the upper vagina can occur, which leads to sexual dysfunction secondary to the shortening of the vagina. Now, the RT treatment toxicities include: first is the bladder dysfunction, that includes the detrusor instability, that is the overactive bladder, and this occurs because of the post radiation fibrosis. The bladder ulceration, incontinence, development of vesico-vaginal fistula. The second complication is the bowel dysfunction, that includes diarrhea, emesis, fecal urgency, fecal incontinence. Sexual dysfunction can occur following the radical hysterectomy and pelvic radiation. Women can experience vaginal stenosis, decreased lubrication and dryness, difficulty in achieving the sexual arousal, and reduced overall sexual satisfaction. Next is the fatigue. The true incidence of fatigue in long-term cervical cancer survivors is not well established. It is estimated that up to 33% of cervical cancer survivors report fatigue 2 years and longer after the treatment. So now the physiotherapy management. Pelvic floor therapy should be done in case if the patient is having any kind of pelvic dysfunction like the incontinence or the fecal problems. And complete decongestive therapy is done for the lymphedema. Conditioning exercises are done for the cancer-induced fatigue. Thank you.